So there are many companies who like to work with me because if it works, I tell it loud. And if it doesn't work, they don't like to work with me because I yell it out even louder. So I was given the opportunity to work under the umbrella of the Clinical Research Office of the Endo Society on a project where irreversible electroporation is being studied. And the discussion with that company took about 3 years before the whole protocols were agreed upon. And it was felt that if you want to position this treatment, you should do all the different steps that either confirms that we should embrace this technology or we should not use it. Well, that's of course a risk for a company to participate in this, and I was very pleased at the end when they decided to support it. If you look at the machine that is being used, it's more or less familiar with all these boxes. If the study design was as such that we wanted to look at the especially side effects, and we wanted to study which was the best tool to monitor the treatment, whether it would be transrectal ultrasound, contrast-enhanced ultrasound, or multiparametric MRI, and we wanted to study what the oncological outcomes would be. The first part of the protocol, we cut the study in 3 parts, was related to a study where we included 16 patients in 2 centers, Amsterdam and Athens. And the concept of that study was that we wanted to see that what we were going to treat was actually treated. And for this, we would offer all these patients who would be candidates for radical prostatectomy 4 weeks before the radical prostatectomy to have another procedure, which was IRE. And after these 4 weeks, they would have the second surgery so that we could objectively study the effects of that treatment. You can hear the setup, you can see the setup, which is the setup, as I mentioned before, like we use it for brachytherapy. And actually the equipment that you see here, it was in our basement. I know it was very costly. The radio-oncologist doesn't need it anymore, but it seems to be costly, and it has been reused at our department. If you look at some of the parameters, you can see that the OR time is roughly 1.5 hours. You look at anesthesia time, but the whole procedure as such with the IRE is only 13 minutes. So if you have a team that is really ready to work on this, you have to keep in mind that you will have to work, depending on prostate size and the preparations, in and about 1.5 hours. If you talk about the total hospitalization in these first 16 patients, including the day they were admitted, the day of treatment, and the day they were going home, was 3 to 4 days. There was 2 patients who stayed for 4 days because they had difficulties to get rid of the Foley catheter. If you look at the catheterization, it can be a little bit prolonged depending if patients would feel comfortable to have their catheter removed and flow well. If you look at the side effects, the majority was in grade 1, 2, and 3. One patient had a urosepsis, and unfortunately this was the father of a colleague. And I discussed with him after the procedure how unfortunate that was, and he says, "Professor, I understand. Since my son is in this hospital also doing research, this is included in the deal." I must say, I was highly impressed by that man. But you can see that some patients had incontinence, and that all resolved, and this was at week 4. We could study it for 4 weeks. It resolved at the end of all the patients after the radical, had no significant effects of this. Some patients had a retention because of the swelling of the prostate, urgency complaints, frequency complaints. But if you look at all of this, at the very end, the side effects studied within the 4 weeks, first 4 weeks, were really acceptable, depending on what you define as acceptable. We looked at the different quality of life parameters, like pain. You can see that was especially the first day. It was increased, but then it disappeared. We looked at sexual functions, which remained unchanged, and that's what it is all about if you talk about quality of life. The the symptoms characteristics didn't change a lot. Quality of life more or less remained the same. We looked at sexual function, as I mentioned, urinary function, and also bowel habits. And of course, we asked the patient at week 4, how happy are you with the outcome? None of them said they were dissatisfied or extremely dissatisfied, even though they had to undergo a second treatment. But the majority of the treatment was satisfied or extremely satisfied. So some of them even asked if they would need a radical prostatectomy. All of them did, but if you look at the appreciation of the treatment, it seems to be okay. We looked at the histopathology, and again you see here some of the slides, and we have made whole mount sections of all the 16 cases. And obviously what was within the treated area, and that was important, there were no skip lesions. So if you would come at the border here, you could still have tumor. But of course, if you would have tumor here and you would have treated it, all of it was erased. And the other thing which was important, you can see very sharp demarcation. We did a similar study, as I said, with HIFU, then you would have these irregular borders. And that's where it was not always sure that you could nicely predict the area that you were going to treat. In the histopathology results, we wanted to know if nerves could be affected. We looked at the urethra, if it was affected, yes or no, and the capsule. And we looked especially if we would go for a more focal treatment or extended focal treatment, and there didn't seem to be a significant difference in those. If you look at the results of the treatment, and that's where we had to learn how large is the lesion that you create when you put the needles. If you put 3 needles, you can see you have a more discrete lesion, and if you put 4 needles like here, you can see that you almost have a complete hemiablation. Now, can you predict the area that is being created depending on your needle positioning? We had a look at this, of course, but interestingly, the electrode configuration resulted in a 2.7 times greater histological ablation zone. With other words, we want to know when we put the needles, what will be the eventual effects. And based on that, we adapted our protocols to be sure that we can properly cover the area that we need to treat. You can see here an example of a patient just on grayscale ultrasound before and after, and if you use contrast, similar as MRI, you can see a complete dark hole here. So we are using contrast-enhanced ultrasound to evaluate after the treatment. You can see here a movie that doesn't run, I think. It runs, miracle. So you can see here the area that has been treated in grayscale when you run through the prostate. And it looks to be an impressive lesion where there's absolutely no vascularity. So this is something which is ready available, it's affordable, and all of us can use contrast-enhanced ultrasound. The same goes for MRI. MRI time is more expensive. We are depending on our friend, the radiologist. But again, if you look at MRI, you can see that the treated area on MRI visualized is more or less matching with ultrasound. And I think this makes it, both MRI and contrast-enhanced ultrasound, very attractive if you want to evaluate post-treatment the effects. We actually also looked at 3D. You can do this all with MRI, and it looks interesting. And we looked at the correlation between the area that we were treating and the eventual effect with contrast-enhanced ultrasound and MRI, and you come to a reasonable good match so that you can predict and plan the area that you want to treat. So in conclusion, we felt that IRE in this first 16 patients who all had radical prostatectomy is safe, that the side effects are acceptable and they are only for a short duration, that you can use either contrast-enhanced ultrasound or MRI to visualize the IRE effects as a follow-up. And we do this on a shorter term because on the longer term, as the prostate is shrinking and the effect is putting in, it's difficult to follow up. But we should be aware that we need to take into account that the total volume treated is a little bit larger than just the placement of the needles. Based on this, we have embarked on a second study. The second study, first one is a phase 1. The phase 2 study is on a randomized study. Again, if you want to have something included in the guidelines, it was felt that a randomized study is serving better here. So we are including 200 patients there in 6 European centers, of which one soon is starting in Valencia in Spain, where we treat patients with a complete focal treatment or a hemiablation. And we're studying here, again, quality of life parameters as well as oncological parameters. And we hope to conclude this study within the oncoming 2 years in these 6 centers to have data that we can solidly rely on outcomes where we give follow-up with biopsies and imaging if this is an approach which is valid. And if the outcome is not favorable, I think we shouldn't embrace it. And we should not continue to search how it can be included. So this is under the umbrella of the Clinical Research Office of the Endo Society. It's an independent from any company that all these data are collected. I must compliment the collaborators of the COLD registry, also because they have demonstrated that collaborative work can give you powerful data with insight and strong conclusions. And this is a similar activity, and I think we should collaborate more and more to come to these achievements. And last but not least, this is not possible with the collaboration of many people. I thank all the people participating in this. And if you want to be involved or want to witness IRE, you're most welcome at our department. But of course, since Valencia is closer by, they're soon starting up. And if you are interested, just have a look at their center. Thank you for your attention.